Top Med Talk.
Nick Harrison here. Welcome to Top Med Talk. This piece is taken from the Perioperative Medicine Shared Interest Group's 2018 annual conference, Measuring, Managing and Minimising Risk, which was held in association with the Australian and New Zealand Society of Geriatric Medicine and the Internal Medicine Society of Australia and New Zealand. Don't forget to check out the show notes on topmedtalk.com for more details. Have a listen.
So the first question is for Professor Peden. Was there dedicated staff, and how many, to promote adherence to the different steps of the bundles of care at EPOC? One, was this left to the hospital itself, and two, can social media have and technology be used to keep clinicians engaged?
Okay, so I think the first question was which part of the EPOC pathway did the hospitals work on? Yeah, people could choose what they wanted. We did try and direct them to the areas where we thought would have most impact, but the difference between EPOC and ELC was there was five sort of 6 factors in the bundle, if you like, in ELC, so it was much clearer what people could work on. So you can argue it both ways. I mean, quality improvement is context specific, so you may know in your hospital there's certain things you want to work on, but I would say that again, that sort of social movement, that getting in the room together, and if you're only working on a small number of things, it's much easier to have those conversations about we did this, it didn't work, and learn faster. So I think if you focus on a few things to begin with, you can accelerate your improvement.
And the next question as well for yourself. Goal-directed fluid therapy was part of the bundle in both EPOC and the ELP-QI. So we know that Floella is currently recruiting, but what was the evidence behind or the reasoning behind using goal-directed fluid therapy in those 2 studies? And second part of that, was there a particular prescription for what was necessarily used and followed?
Well, if you remember the history of this, there was a big push in the UK for everybody to get goal-directed fluid therapy, and then it kind of fell out of fashion, if you like. But if you look at Mike Grocott's Cochrane review, there is evidence in the highest risk patients that it's beneficial, and also the optimized study, I think. I mean, if I look at those survival curves, I would want goal-directed fluid therapy, if you look at the optimized study. And actually, that was, the way we were thinking when we created ELP-QI. And if you look at the factors that were significant in ELP-QI, goal-directed fluid therapy was one of them, which is why we put it into the Emergency Laparotomy Collaborative. But it was controversial. And one of the things in quality improvement is don't fight battles that you don't have to fight. And we realised with EPOC, if we went, Tim Stevens and I went into hospitals and we went around 90, or we met with 90 hospitals around the UK, if we picked on goal-directed fluid therapy, which was controversial, we couldn't move people past that to do the simple things. So I would say also think about the simple things you can do first before you get into the more complex ones.
Okay. And another question, how do you know mortality improvement is in those numbers is due to care bundle rather than more non-operative management in the highest risk patients, i.e. did you collect a denominator?
Well, this, as my colleagues were saying, we tried right from the beginning to collect the patients that weren't operated on, and if you go back to our original work in Bath, we always wanted to do that. And I would think with the people we've got in the room here now, part of the problem is patients come in under the physicians and the surgeons never know about them. So unless you're getting a hospital-wide survey every morning, it's very, very hard. But I'd be interested in my colleagues' thoughts on that.
I think part of the answer in the question is what Ben's already alluded to and what they're going to try and do in New Zealand. One of the other problems with the data that comes from Neula and with the improvement is the risk adjustment. Now, one of the reasons that my hospital's not yet in ANZELA is because we do NESQIP. And NESQIP gives you that risk-adjusted data. and I'm having trouble selling them changes with Nesquip and quality improvement with Nesquip as it is, to try and get them to do another program. We're probably a few months off yet. But to get back to it, what you really require is the geriatricians on board, because a lot of the patients that come in with an acute abdomen, the gastroenterologists, if they can't scope it and they've got a bellyache, they'll ring you as a general rule. But it's getting the geriatricians on board that have the patient that comes in with, that the general surgical registrar doesn't want, and, they just sort of drift in. And we found through our COPS project and an improvement in the management of our surgical patients and the interaction with the geriatricians, all of a sudden we were getting a lot more referrals from them early on their patients that were coming in with problems that weren't obviously an acute abdomen, that then later became clear that it was an acute abdomen. So I think doing some of these other projects where you have an increased collaboration between groups and you're breaking down the silos is the answer to the question, so that you don't have those patients going under the radar.
Yep. And I guess a bit of a follow-on from that is, does measuring and publishing perioperative mortality data, it's a question whether this adversely affects the high-risk surgical patients, in that does it affect a surgeon's decision to operate or not, and would that potentially lead to inadvertently, or someone who could have been saved by the operation, I guess, is the question.
That's always a risk, and that's difficult. And there's no doubt that within our own unit, there's some of the guys that are risk averse and some that will jump in anyway. And so where you get around that is having a protocol-driven decision-making tree, so that you can't have somebody go underneath. And things like Ruby in our hospital, she wouldn't have waited 3 days. Bowel obstructions can't wait longer than 48 hours. Things like that you have protocols that then, and you audit those protocols, and then you sort of challenge people as to why, well, hold on, our protocol says 48 hours for a small bowel obstruction. Why did this patient wait 5 days? And they're a bad outcome. So a lot of it is having the protocols, reviewing your data, and again, if I can put another plug in for Nesquip, Nesquip is risk adjusted. Okay, so Arthur Richards and I have driven this within Western Sydney, and we will stand up at meetings and regularly tell people that know us fairly well, Arthur and I can no longer, he can't say he does more complex work at Westmead, and I can't say that all mine are fat diabetic smokers, because it's all risk adjusted.
Yep. So your slide. And the next question is, do you have consultant geriatricians available after 6 to come and...
That's why I kept on painting a very good picture of how important the geriatricians are. It is difficult to have somebody available out of hours. But I think if we're going to be looking at the data and looking at the improvement, we had a lot of trouble when we first created our consultant surgeon ASU. So we have a consultant surgeon in the hospital 7 days a week, 365 days a year. 2 years' time, we get a bonus day every single day to assess the patients. And we've greatly improved our outcomes. Our risk of mortality on weekends our odds ratio is actually 0.95. Most hospitals' risk ratio or odds ratio for mortality for a weekend operation is 1.1 or 1.2. Okay? So we just need, it's not so much the geriatricians aren't interested in doing it, it's creating the funding that allows them to be able to do it. That's the real problem.
Okay.
Just say, I think, I don't think, I mean, ideally, the geriatricians would see the patient, that night, but I think they just need to be seeing the patient soon, like the next day. There needs to be an automatic referral, so the patient's not waiting, it's part of the pathway, part of the process.
Yep.
We've got a key person in the front row in the COPS project. You might want to tell us your thoughts on it, because certainly the data from the COPS project was between Nepean and Prince of Wales. Prince of Wales was the lead hospital, and the outcomes are really very, very good. And we just need to convince our data our funders to increase the funding for the geriatric registrars and the geriatric consultants so they can actually run these services.
And another question as well for Professor Cox. How, as a surgeon, do you feel if to operate on a patient who you might feel is borderline or futile? However, the consensus, largely from the patient, next of kin and your colleagues, is to go ahead with the procedure?
I don't have a problem if there's been appropriate risk calculation, and if there's been open and honest discussion about the risks, and the family bounces, and it's often the family, it's often the children, bounce back and say, we want everything done possible. Usually you've then been able to introduce the concept of limits of care, such that, okay, they may go to ICU, they may be on a ventilator, but if they're no better within 24 hours, we're going to pull back. So usually, provided you've done the risk adjustment and had those discussions, I might not necessarily agree with the decision, but at the end of the day, it's the family's decision. And provided they've been properly informed, and that's difficult to measure sometimes.
Yep. Good. Ben, is there a standard process built into the ANZELA-QI database to communicate practices of the top performing hospitals compared to the less well performing?
No, but that's a very good idea. If we can use that, if you don't mind, I'll take that.
And another question as well that from the
social
audience.
media platform would probably be one way to communicate that.
I was just going to say, one of the top performing hospitals in EPOC, they did the red, amber, green thing, but I think it was driven by one clinician who was very passionate, and she did a little report card for the surgeons, the anaesthetists, intensivists every month. So it was very, very effective. Oops, I'm red this month, I better pull my socks up.
Also,
particularly if that's confidential. You need to make it. We do a similar thing with the NESCRIP data. I don't have the codes for the surgeons. The surgeon champion does. And he'll go and have I know where I sit. I sit okay because Tony's told me. But he'll go and have quiet discussions with colleagues, and they do change their behaviour as a consequence.
From NELA, I believe there are now certain hospitals that have survivor groups where they have morning tea. Are you aware that has actually led to any changes or how people approach emergency laparotomy surgery?
Yeah, I think that's some of the hospitals in the south of England who were in ELC, and I think it's a great idea. I think, the more patients we get involved, again, hearing the patient's voice, incorporating that into the way we design these pathways, and having those conversations, or even having some patient expert that can perhaps talk to a family member about what this really means would be I think it's a fantastic idea.
Okay. Yep. All right. That's the end of our session. Thank you very much to our speakers.
Lee Majerison here. Thanks for listening to Top Med Talk. Now, before we let you go, it's important that we remind you to subscribe to Top Med Talk. That way you'll never, ever miss another episode. Also, if we could encourage you to join us on social media, Twitter, Facebook, LinkedIn, YouTube, pretty much every single social media platform, we're there. Join us. And finally, check out topmedtalk.com. If If you go to our website, you can subscribe to email updates. That way we can always tell you where we're going to be, what we're going to be doing, and how you can join us. topmedtalk.com and click on the section marked email updates. Finally, Top Med Talk is proud to act as the broadcasting arm of EPOM, Evidence-Based Peri-Operative Medicine. We'd love you to find out more about them as well. ebpom.org is their website. That's ebpom.org. And if you go to ebpom.org/meetings, you can find out about some of the wonderful meetings that we attend and cover across the year here on Top Med Talk. That's ebpom.org/meetings.